with long history of osteoarthritis. If a patient with long history of osteoarthritis, there is a chance of pes anserin bursitis associated with it. And also pes anserin bursitis may associated with a patient who is more walking uphill and downhill. And this pes anserin bursa is the attachment point of three muscles. And another thing is, to diagnose the pes anserin bursitis, the patient felt pain 2 to 3 centimeter distal to the medial joint line. I will explain the medial joint line in the further slides, how to diagnose pain in the medial joint line. And 2 to 3 centimeter distal to this medial joint line, the pes anserin bursa is situated. And this in pes anserin bursitis, surely we can elicit tenderness, but to confirm the diagnosis of pes anserin bursitis, we can do another clinical examination test. I will explain it. The patient is in prone position. And the patient's knee is flexed to 90 degree, and ask the patient to again flex the knee joint from 90 degree against our resistance. Ask the patient to flex the knee joint again in prone position from 90 degree against our resistance. Then the patient felt pain at this pes anserin bursa. And this is pes anserin bursitis. This is a picture of right knee joint in flexed position. This particular knee is flexed 90 degree, and this is of right knee joint. In the initial phase, we saw the pictures of left knee joint. Here it's a picture of right knee joint in 90 degree flexed position. The other two pictures which we saw is of extended position. Here we can clearly see the anterior cruciate ligament, and this is posterior cruciate ligament, cross-shaped, and this ACL is attached to the anterior tibial plateau. ACL is attached to the anterior tibial plateau and PCL to the posterior part. This medial collateral ligament is closely attached to medial meniscus, but there is no connection with lateral meniscus and lateral collateral ligament. This is the tibial tuberosity. This is regarding meniscus. The structures which is used to bear weight, that means it acts as shock absorbers, just like this. This is medial meniscus, which is C-shaped, and this lateral meniscus is O-shaped. Whether you can send me a message whether this knee is right or left in chat box. Those who are attending class, will you please send me a message whether this is right knee or left knee? You just send message. Two options are there, 50% probability. Just feel free to send messages. This knee joint is right knee joint. How we can understand is by looking the tibial tuberosity. This is tibial tuberosity, and with this tibial tuberosity, we can find out that this is of right knee joint. And please note, this is the medial meniscus, this is the posterior cruciate ligament. This is the anterior cruciate ligament, and this medial meniscus is C-shaped. Lateral meniscus is O-shaped. Please note that the periphery of menisci is only vascularized, and the inner part of menisci is not vascularized. And this is the transverse ligament, which is an intracapsular ligament, which we saw in the second slide. This is the transverse ligament. Okay. And this is from the posterior aspect. This is the femur shaft. This is the medial condyle. This one is the lateral condyle. and this is the medial collateral ligament. This is medial meniscus. This is lateral collateral ligament. This one is lateral meniscus. Okay, this picture is from the posterior aspect. And the ligament functions. Medial collateral ligament prevents medial opening up. If there is complete tear of medial collateral ligament, when we are doing a test known as abduction test, in abduction test, if there is partial tear, then there will be excruciating pain over the femoral attachment of medial collateral ligament. I already explained that the more common site of injury to the medial collateral ligament is at its femoral attachment, so that whenever there is partial tear, whenever we are doing abduction test, there will be excruciating pain. And if there is complete tear, then there will be opening up. There will be medial opening up of the joint. I saw this particular condition while doing a clinical examination in a particular patient, and that particular condition is surgical. Complete tear of MCL means it is surgical. So this medial collateral ligament, its function is to prevent the medial opening up. It's basic common sense and logic. But we should know this particular functions. And this lateral collateral ligament prevents lateral opening up. And anterior cruciate ligament prevents anterior translation of tibia on the femur. And this posterior cruciate ligament prevents the posterior translation of tibia on the femur. Please know these things. It's just common sense. And this is regarding the bursa. Please note the site of this bursa. This prepatellar bursa is in between the patella and skin. And infrapatellar bursa, actually this bursa is to avoid friction in between the muscles. And the infrapatellar bursa is situating at the both sides of the tibial collateral ligament or patellar tendon. That patellar tendon means the muscle connecting or ligament connecting from patella to the tibial tuberosity. And that patellar tendon, both sides, this infrapatellar bursa is situated. And infrapatellar bursa consists of peripheral and deep part. And this is the pes anserine bursa. Hope you remember the clinical examination of pes anserine bursitis, which I explained earlier. That means the patient is in prone position and ask the patient to flex the knee joint against our resistance from 90-degree flexion. And this is the suprapatellar bursa. Whenever there is injury to knee joint, if it's of minor injury also, there will be suprapatellar bursitis. Immediately, this bursitis will occur. And hope all of you visualize this. In osteoarthritis patients also, from the very beginning, there will be suprapatellar bursitis. We can see there will be bursitis at the suprapatellar pouch. And this picture is from anterior, and this is from lateral. Actually, this is known as sagittal. This particular lateral view is known as sagittal view, and this view is known as coronal view. Whenever we cut it like this, then it's axial view. Now, please note this one is coronal and this one is sagittal. Please note that this is the suprapatellar bursa, and this one is prepatellar bursa. Prepatellar bursa is in between patella and skin. And there is infrapatellar bursa, which is subcutaneous and also deep. And there is pes anserine bursa. And this is semimembranosus bursa. And this semimembranosus bursitis is actually causing Burkitt's cyst while doing clinical examination or in imaging. You may notice this Burkitt's cyst. And the Burkitt's cyst is due to a primary disease due to osteoarthritis or rheumatoid arthritis. There is no particular management to Burkitt's cyst. The management should be done for the primary disease, that is osteoarthritis or rheumatoid arthritis, and the management to that particular primary disease itself reduce this Burkitt's cyst. And there is a chance, it's a rare chance, to whenever there is a chance of break of this Burkitt's cyst, there is a chance of bursting of this Burkitt's cyst. Actually, it's a rare condition. I only saw 2 cases in my clinical practice, and that particular condition may cause bruising at the calf region on the first day or second day. Whenever we took an ultrasound scan, we can see that the Burkitt's cyst is bursted, and due to gravity, it radiates distally, and that bruising will radiate distally, and it subsides by itself. It subsides within 1 week by itself, but it radiates up to the foot. That condition is a rare condition, but I am just sharing that particular condition. There is a chance of breaking of Becker cyst, which may cause bruising from this particular area up to the calf region. Okay. Extensor apparatus of knee I already explained. It consists of, from proximal to distal, this quadriceps muscle, quadriceps tendon, patella with patellar retinaculum and patellar tendon. A failure to any of these structures result in inability to do the active extension or to do the straight leg raising. These are the structures: quadriceps muscle, quadriceps tendon, patella and patellar tendon. Please note these muscles also. These muscles, this quadriceps muscle consists of these structures, 4 muscles, and this vastus medialis muscle or vastus medialis obliquus muscle is the first muscle to be affected in any pathology related to knee joint. Please note, in any pathology related to knee joint, the first muscle which starts wasting is vastus medialis obliquus, VMO, and definitely we must learn the rehabilitation of these structures, all the quadriceps muscle, and definitely to this vastus medialis obliquus rehabilitation is of very much importance in the patency of knee joint. To maintain the activities of that particular knee joint in any pathological conditions, the rehabilitation of VMO is of utmost importance. We can learn it easily through Physiopedia, that particular site. And regarding clinical examination, the basic of clinical examination is by clinical DAS. And after learning clinical DAS, we can go to McRae or Adams, that is clinical examination of orthopedic test. And after learning McRae and Adams, we can go for Readers. Readers is an American test, and that test is very good text to learn the clinical examination. And in site, we can use AAOS or OrthoInfo, American Academy of Orthopedic Surgeons, to learn the clinical examination and to learn the radiological findings, to learn X-ray, and up to MRI. We can definitely use Radiopedia and Radiology Masterclass. We can use it daily for 10 minutes, 10 to 15 minutes. Within 6 months, we can learn all the radiological aspects very well. Okay. And this is patellar tendon. Please note the patellar tendon, tibial tuberosity, and all these structures, muscles. Why? Because there may be a chance of hamstring tendonitis and gastrocnemius tendonitis. To rule out such things, we must learn it. But please note, whenever we diagnose a condition of hamstring tendonitis, please look for 2 things. Please look for 2 things. That is important. Now, why? Because some doctors may do Agni-Arma to this hamstring tendonitis without diagnosing the primary cause. And it definitely ends with recurrence. Within 1 or 2 months, sometimes the patient may come to us, or otherwise the patient may go to other doctor. So the primary cause of hamstring tendonitis, it may occur as a primary disease, but also it may occur as secondary to osteoarthritis of knee joint and also due to spondylolisthesis. It's a spinal condition, that spondylolisthesis. The spondylolisthesis, due to this spondylolisthesis, there will be exaggerated lumbar lordosis. To maintain the exaggerated lumbar lordosis, there will be more strain to the hamstring tendonitis, and this hamstring tendonitis is the reason, secondary disease to the primary spondylolisthesis. In such conditions, it is better to avoid Agni-Arma. Why? Because treat the primary disease, and treating the primary disease will end the secondary disease. So that such conditions we may keep in mind. Also, another thing, this is of very much importance. Why? Because patient may complain pain in the medial aspect of knee joint, but the reason of pain may be avascular necrosis. In avascular necrosis, the pain pattern is starting from the hip and it radiates distally and it ends in the medial joint line. It ends in the medial joint line. It is going medial to the knee joint, and the patient may present pain at the medial part of knee joint. But the reason of pain is avascular necrosis related to hip. So that in all conditions of knee joint, definitely spinal and hip examination is of utmost importance. After examining the knee joint, without examining knee joint, no. After examining the knee joint, definitely we should do the basic clinical examination of hip and spine. For that, we can do an SLR and also basic palpation of the spine and hip, and also the hip range of motion in sitting, supine and prone position. In sitting, supine and prone position, the external rotation and internal rotation of hip should be examined, and the internal rotation of hip should be examined in the prone position. In the prone position, the internal rotation of hip should be examined, and by that we can rule out whether there is any pathology related to hip or spine and it is causing pain at the knee joint. Also, whenever there is anterior thigh pain, the patient presents pain at the distal end of thigh, anterior thigh, but the reason of pain may be L1, L2, L2, L3, L3, L4 lesion, upper lumbar lesion. For that, we must do an FNST, femoral nerve stress test. So that please keep in mind, whenever a patient comes to us with a pain at the knee joint, definitely after doing the clinical examination of knee joint, please look for any primary disease related to hip or spine. And please note the medial joint line. I will show the video of palpation of medial joint line in the coming slide. Please note the structures: quadriceps muscle, quadriceps tendon, patella, patellar tendon, and this is tibial tuberosity. This is patellar tendon, lateral joint line, medial joint line. This medial joint line and lateral joint line should be examined in 90-degree flexed knee joint. I will show that pictures. And this structure is also very important. This is the posterolateral corner of knee, PLC. Don't confuse it with PCL. PCL is posterior cruciate ligament, and this structure is PLC, posterolateral corner of knee. Sometimes we may think why the patient with ACL tear, complete ACL tear, is walking again. Why this patient with ACL tear is walking again without any problem? We may confuse whether the patient is not having complete ACL tear, but we can do it with clinical examination. With Ligaments test, we can confirm whether there is complete tear. If there is anterior translation up to 1 centimeter, then definitely there will be complete tear. And the reason for the patient to walk again properly with complete ACL tear is the posterolateral corner of knee. This posterolateral corner of knee, which consists of lateral gastrocnemius tendon, popliteofibular ligament, and this popliteus tendon. Three things: popliteus tendon, popliteofibular ligament, and the lateral gastrocnemius tendon. To check the patency of this posterolateral corner of knee, we can do dial test, but this is not coming in this particular session, so I am leaving. Please note this posterolateral corner of knee. In the applied anatomy part, this particular area is of utmost importance. So please note these structures, which consists of this lateral gastrocnemius tendon, popliteofibular tendon, and then popliteus tendon, which is posterolateral corner of knee. And to check the patency of this PLC, we can do a test known as dial test, which is done in prone position. Coming to the range of motion, this is very important. Look, feel and move, assessing the range of motion. Why? Because in each review, we can assess the range of motion to check whether there is improvement or not. If a patient with osteoarthritis grade 2 come to us, and on each clinical examination, whether there is no improvement in the range of motion, that means our treatment is not working. So to know the change, we must do the clinical examination. And if a patient comes to OPD with osteoarthritis grade 2, and on the first review after 2 weeks, the patient is saying that there is no change in pain, whenever we are doing the range of motion from the first review, in the second review, what is the change in the range of motion, then we can definitely say that whether there is improvement or not. For that also, this clinical examination and assessment of range of motion will help us. The flexion of knee joint is up to 120 to 150 degree, may differ. So that we must definitely check the normal knee joint. So that I already explained that in every clinical orthopedic setting, first we should do the examination of normal knee joint, and then the affected knee joint. So that in the normal knee joint, whether the range of motion is 120 degree, and in the affected knee joint it's 120 degree, then means the range of motion is normal. And please note that on normal active flexion, the heel does not touches the buttocks. But whenever we are doing passive flexion, then the heel touches the buttocks, and that is normal. And it is above 150 degree. Please note that whenever we are doing passive flexion only, the heel touches the buttocks and it is above 150 degree. The flexion is above 150 degree when the heel touches the buttocks. And the second thing, if we are not having a goniometer and we can't measure the flexion correct degree, we can measure another distance. That is the measure the difference in between heel and buttocks in each review. That means if a patient with osteoarthritis grade 3 is coming or chondromalacia grade 3 is coming, when in that particular condition the flexion will be surely affected. And in that condition, in the first review, measure the distance from the heel to the buttocks, and on second review, measure the change in the measurement from heel to buttocks. That way also we can assess the flexion. Extension 5 to 10 degree or 0. Internal rotation and external rotation is only in 90 degree flexed knee joint. It is internal rotation is 10 degree and external rotation is 30 to 40 degree, but no need to measure this. Why? Because it's not much clinically important. And regarding knee dislocation myth, I am saying why, because some doctors itself say that knee joint is reduced after the diagnosing the dislocation. But please note that the dislocation occurs in knee joint, which can be do conservative management, and reduction with conservative management is possible only in the dislocation of patella, in the dislocation of lateral displacement of patella. Patella displaces always to the lateral side, and this lateral displacement of patella can be reduced conservatively. Whenever there is lateral displacement of patella, the patient is unable to do the extension of knee joint. And in Susruta Samhita, Bhagna Chikitsa, it is explained that Janu should be reduced same as that of Purpara. And the reduction of Purpara Sandhi Vislesha is Kaurpuram to Dada Sandhi Angushtena Anumarjed Anumrjya Tada Sandhi Pidayet Purpara Chudam Prasarana Agunjane Jegam Sneha Sekanja Dabe. This is the reduction method of Kaurpura Sandhi Vislesham. That means Kaurpuram to Dada Sandhi Angushtena Anumarjed, using the thumb. Anumarjanam or Anumardhanam should be done. And the second thing is Prasaranam, that means extension. And the third thing is flexion. It should be done. In patellar displacement, lateral displacement of patella is displaced over the medial femoral condyle. The reduction method is using our thumb, give medial pressure to the medial side. Why? Because the displacement is lateral. So that give pressure to the medial side and then extension is done. Prasaranam is done. By doing this, the patella will be come to normal position, and this is the reduction method of lateral displacement of patella. And it is possible to do the conservative management with 3 weeks immobilization. In all dislocation, 3 weeks immobilization is must, and in patellar dislocation also 3 weeks immobilization should be done, and then ask the patient to do the rehabilitation. Regarding knee dislocation occurs only due to severe RTA. As knee is a complex structure, large joint with lot of ligaments, the knee dislocation occurs only due to severe RTA, and this due to the severe RTA, whenever there is knee dislocation, that means definitely the structures I explained, that is ACL, PCL, MCL, LCL, there will be tier to 2 to 3 structures minimum as part of knee dislocation, and this knee dislocation requires surgical correction, and that injury is of very much potential risk. Why? Because there is a chance of injury to popliteal artery. In that condition, the distal end pulse should be checked immediately, posterior tibialis pulse should be checked, and that patient should be referred immediately for surgical correction. Immediately after the reduction of dislocation, surgical repair should be done for the injured structures, and it is not possible to reduce the knee dislocation conservatively. And in all knee joint injuries of ligament tear, there is no need of any reduction. Reduction causes nothing to that injury, so that it's better to avoid unnecessary traction and manipulations in an injury related to intracapsular ligaments. Why? Because we should do all the practice scientifically. So that I am explaining this regarding knee dislocation, it won't happen without severe RTA and it should not be managed conservatively. In all other conditions, only the reduction method need in knee joint is patellar displacement, which is of lateral displacement. I already explained the reduction method. In all other conditions, there is no need of any manipulations in knee joint. Please note. And very important regarding knee joint is the spine and hip examination. Spine and hip examination. Okay. We can see the patellar ligament. I will show. This is the patellar ligament. The structure which I am pressing is the patellar ligament. Patellar ligament is connecting the distal end of patella to the tibial tuberosity. It is included in the extensor apparatus. Please note this is the patellar ligament, and this patellar ligament can be very much palpable in 90-degree flexed knee joint. Whenever on extension, it should be more tight. Here we can easily palpate it when it is 90-degree flexed knee joint. And just medial to the patellar ligament is medial joint line in between medial femoral condyle and medial tibial condyle. Just lateral to patellar tendon is lateral joint line. Please note these structures. This is very important. This lateral joint line in between lateral femoral condyle and lateral tibial condyle. If you are sitting in 90-degree flexed knee joint, you can easily palpate it from patellar. Just distal to patellar, there is patellar tendon. And just medial to it, we can feel a hollow space in between medial femoral condyle and medial tibial condyle, that is medial joint line. We can see the palpation of medial joint line in the neck structures. Please note this is patellar ligament. In the clinical examination of patellar tendinitis is ask the patient to do the extension of knee joint against our resistance from this position. I will show that. This is the medial joint line. Medial joint line. In osteoarthritis knee joint, the most painful area is this medial joint line and then vastus medialis obliquus. In osteoarthritis, fresh cases with grade 2 osteoarthritis itself, definitely there will be pain on the medial joint line and the VMO. Whenever there is a patient come to us with grade 3 osteoarthritis, and this grading is very easy, it can be learned with KL scaling. It is in Radiopedia, KL, Kellgren-Lawrence scaling. By that, we can definitely assess the grading. And this grading is also very much important in the assessment of prognosis. And the diagnosis and prognosis is very much important just before the management. First thing, diagnosis means by knowledge. Diagnosis, the meaning of diagnosis is by knowledge. And prognosis means before, gnosis means knowledge. And we can understand early that what happens to this disease, whether we have prognosis in this particular condition. If there is no prognosis, if it's a grade 4 osteoarthritis and the patient needs more walking and weight bearing, then our prognosis is not good. But if a patient comes to us with grade 4 osteoarthritis and the patient need not need much activities, that is important. The demand of patient. The patient only need to walk inside the home without climbing stairs, then we can manage. Our prognosis is good. But when the patient needs to walk upstairs and need more weight bearing movements, then if it's grade 4, our prognosis is not good. And that for assessment of prognosis, this clinical examination is very much important. And this is the medial joint line. Please note, the medial joint line is in between the medial femoral condyle and lateral femoral condyle, and it's very much felt in 90-degree flexed knee joint. And just distal to this, on the medial aspect, we can feel this pes anserine bursa for pes anserine bursitis. And just proximal to it, we can feel the medial collateral ligament. This is the lateral joint line. Please note this lateral joint line. The understanding of lateral joint line is very much important in the understanding of iliotibial band syndrome. Please note this lateral joint line is just lateral to the patellar tendon and in between the lateral femoral condyle and lateral tibial condyle. And this the most common pain site of iliotibial band syndrome is just 2 centimeter proximal, 2 centimeter above lateral joint line. The most common site of pain of iliotibial band syndrome is just 2 centimeter proximal to lateral joint line. So that these structures are very much important. And please note that whenever there is tear to meniscus, if it's medial or lateral meniscus, there will be tenderness in the joint line. There will be tenderness in the joint line. Joint line tenderness can be elicited. And as we all know, in all structures regarding this tendonitis or bursitis or fasciitis, in such structures, there will be a particular point in lateral epicondylitis. The pain is very much felt at its attachment of lateral epicondyle. In medial epicondylitis, pain is exactly over the medial epicondyle. But in iliotibial band syndrome, the difference is that the iliotibial band syndrome is starting from the hip region, and it traverses down in between the tensor fasciae lata and this gluteus medius and gluteus maximus muscle, and it is traversing down distally towards the lateral side of thigh, and it is attaching at the lateral condyle of tibia. It is attaching at the lateral condyle of tibia. But the most common site of pain is at the lateral femoral condyle, just 2 centimeter proximal to the lateral joint line. Why? Because in flexion and extension of knee joint, there will be more friction at this particular site to the iliotibial band. So the site of pain is at the lateral femoral condyle, just 2 centimeter proximal to the lateral joint line, which is very much common in marathon runners who are doing cycling and who walks uphill and downhill. Coming to the clinical pictures which we need to discuss, it includes the patellar tendonitis, bursitis, Chondromalacia patella, and iliotibial band syndrome. Coming to these structures, to these particular clinical findings, just before that, we can go to the differential diagnosis of acute monoarthritis. This differential diagnosis of acute monoarthritis consists of mainly this is applicable to all joints. This particular condition, this differential diagnosis of acute monoarthritis is applicable to all joints in the body, but it is this example in the Adams is mainly regarding knee joint. We shall go through it. Whenever a patient with a monoarticular pain, one single joint pain come to OPD, what should be our differential diagnosis? What all things we should keep in mind while doing the clinical examination or come to the conclusion of diagnosis? The first one is congenital. It may differ from one joint to another, but I already explained that there is a one congenital condition called congenital bipartite patella, in which it may misdiagnose as fracture, which occurs at the supralateral aspect of knee joint, and there won't be any tenderness at that particular site. But when we took an X-ray, it looks like a fracture. And to differentiate that, in all congenital conditions, to differentiate whether